retrospect, we're going to pop back. Okay, thank you. In retrospect, you go back and you see here's the stroke here, and you go back and you go, oh, look at that. There it is there, right? So sometimes it's kind of hard to see, and then it's more obvious. But MRI is usually the modality of brain imaging of choice for TIA and minor stroke. And we often use it after somebody has some kind of a deficit, but the CAT scan's negative. You know, some people say, okay, well, you know, they may or may not have had a stroke. What's the, you know, what difference does it make? And a lot of older people, it really matters because, you know, someone may not be doing well at home. They may have multiple medical comorbidities. Family's just barely managing, and they've had something happen. Maybe they're dysarthric or something happens and it passes and people think it's a stroke, but the CAT scan's negative. It's so important to confirm whether or not somebody has actually had a stroke, because I mean, if they have even a small one, it's a new brain injury above and beyond, you know, someone's often brittle baseline. And so, you know, a discharge, you know, may not be warranted. The patient may not be able to manage even with a small stroke. It could be a straw that broke the camel's back kind of thing. But on the other hand, if the MRI is negative, you know, in all likelihood, the patient has not had a stroke. We debate sometimes the concept of an MRI negative stroke. It is a bit controversial. I'm one of the people that doesn't think such a thing exists. When MRI was originally developed, we didn't have all the different sequences we have now. We just had what we call the T1 and the T2 weighted sequences, and the spaces were pretty far apart, the slices. So you could definitely miss a stroke on an MRI back in those days. But nowadays, you know, we've got additional sequences, namely the diffusion-weighted sequences, which I'm showing you here, which a stroke you know, it lights up like a beacon. It's very easy to see. And moreover, the slices are a lot narrower. And the other thing is that it's 3 dimensions now. And brain imaging is not just top to bottom, it's also front to back and side to side. So it's exceedingly unlikely that someone has actually had a stroke if the MRI is negative. I tell the residents it's a very dangerous thing to suggest, because what it means is if you stop thinking about it, you've stopped thinking about the patient's case. This patient has a right-sided weakness. Oh, the MRI is negative, but maybe it's still a stroke. What are you talking about? You have not confirmed your diagnosis. What if it's a peripheral nerve problem? What if it's this? What if it's that? You got to keep thinking. If the MRI is negative, you're wrong, basically. So, so in terms of the etiology, you know, we divide our approach to stroke. I think really we look at small vessel disease and then kind of large vessel disease. So this MRI scan here is showing us a lacunar infarct. It's an example of small vessel disease, right? And so here's a schematic showing, you know, what small vessels are we talking about. Can everybody see my little cursor there? I'm moving the arrow around, maybe. Yeah, they can. Okay, good.
Yes.
So yeah, here these little so this is the terminal portion of the internal carotid artery after it's entered the skull and gotten into the brain. And right here, the terminal ICA splits into the MCA and the ACA. And so this first part of the MCA, it's called the M1 segment up until where it splits again. And along the M1 segment, off of this large vessel, you see all these small penetrating vessels. And we call these the lenticulostriate penetrators. And throughout the brain, you have small penetrating vessels like this. And so what happens, I mean, I guess it's conceivable that a clot might have traveled along, stopped maybe here for a while, and then caused a little infarction, and then continued on. But that's not really what happens. These small vessels, they harden, they narrow, they develop what we call, the pathophysiology is something called lipohylenosis. And, you know, the day comes that they fail. And so that's how you can have a lacunar infarct, because the penetrator has just, you know, ceased to function and the blood flow is stopped. Now that may involve a clot. Like it could be that there was what we say a microatheroma, a very small atherosclerotic plaque, maybe at the origin of these vessels or something. And It ruptured and a little clot was, 2 or 3 platelets, all you need to close something off. But really, small vessel disease is a manifestation of someone's, vascular risk factors. So, as you do the rest of the workup, and let's say everything else is negative, these 4 risk factors, I sometimes call them like the 4 horsemen: hypertension, diabetes, hyperlipidemia, and smoking. And I mean, you just spent the whole first part of the workshop talking about these and other risk factors. But if you want to decrease the likelihood of another small vessel lacunar infarct, yes, obviously antiplatelets help. Believe it or not, there's a little bit of debate as to whether or not they help that much with small vessel disease. It must help a little bit at least, but really you want to optimize the person's vascular health. And that's totally the goal. So you want to optimize their blood pressure, optimize their blood sugar control, optimize their lipid profile, and you want obviously them to quit smoking. And so I often think of these 4 vascular risk factors as kind of a tetrad or something. And that's the strategy for small vessel disease. Obviously antiplatelets help as well, but that's the approach there. So I'm going to stop for a moment, and before I go to the next kind of investigations and etiologies, I want to ask, how do people want to do things? Do you want to ask? I'll stop frequently and people can ask a few questions. I think it's probably better to kind of punctuate it with a few little pauses. Any questions about this first part? Not really? Okay, I mean, pretty straightforward stuff.
You can either unmute or you can write your questions in the comments.
Okay. So let's move on. Someone's had a stroke, and let's suppose you've seen it on the scan. And so this is a large vessel infarct. Okay, so this is an anterior cerebral artery territory infarct. So this person has had a interruption in blood flow in, actually it's the ACA territory here, and you can see a little bit in the MCA territory, a little patch of infarction there as well. So anyway, this is a completely different mechanism than the small vessel disease, the failure of those penetrating arteries. This is screaming out that a clot formed somewhere, and it formed, and it either formed in the brain itself, sometimes it happens, or it formed in the neck, or it formed in the heart, formed elsewhere and passed through the heart, and up it went, and it got stuck, and it interrupted blood flow to a part of the brain for long enough for brain damage to occur. And so this is, and so whereas with the small vessel disease, it's really one etiology. Small vessel disease, I mean, there's some rare things, there's vasculitis and some other things, but for a single subcortical infarct, it's really small vessel disease. Once you get into what we call a cortically based infarct, this is a cortically based infarct. What I mean by cortically based is that the infarct, this dark gray area, it's a wedge of infarction. There's the wedge, with the base of the wedge really involving the gray matter of the cortex, as well as the underlying white matter, right? So you often hear the term cortically based infarct. If we go back a little bit to the lacunar infarct I showed you, this is not cortically based. This is buried deep within the subcortical white matter. Actually, it's actually bordering on some of the subcortical gray matter as well, but it's nowhere near the cortex. The cortex is the surface of the brain, so it's far away from there. So now we've got lots of possibilities. So what do we want to do? So more and more, the next step is a CT angiogram. So here's what a CT angiogram looks like. We often look at the patient's blood vessels from the aortic arch here at the bottom, all the way to the vertex, the top of the brain. So from the arch to the vertex, and so we see the blood vessels coming off of the aortic arch, we see the internal carotid arteries. This white stuff is calcium. Calcium is like human rust, so it just kind of shows up over time everywhere. And then inside here we see the intracranial vessels. And so sometimes, more and more, what's being recognized, and this is a picture of a conventional angiogram. Sometimes we see an intracranial stenosis here. So there's a narrowing of the blood vessel inside the actual brain. So this is actually, I mean, those of you who've been involved in the stroke system for a long time, are obviously familiar with carotid disease and cardioembolic stroke, and this is really something that's being focused on more recently. So what do the Canadian stroke best practices have to say about intracranial stenosis? So if you have a stroke in the vascular territory of an intracranial stenosis, and how does the stroke happen? I'll go back a second, I'll say it. So it's not so much that the blood can't get through and you have a stroke. It's like what happens in the neck. The stenosis is from a plaque that has built up in the blood vessel, and that atherosclerotic plaque, it can attract platelets, so it might have a thrombus kind of form on it, but more often than not, these plaques at some point they rupture, and when they rupture, the interior contents are very thrombogenic, and so then right away your coagulation cascade kicks in, and then you have a clot form at the site of the ruptured plaque, and then that stops the flow immediately. What might happen is with the buildup of pressure, that clot might move downstream, and you could have a stroke. And what we call this is an artery-to-artery embolus. An artery-to-artery embolus can all be intracranial, so it could be from your middle cerebral artery proximally to distally, or an artery-to-artery embolus, a thromboembolus we call them, because it's a thrombus that formed on a ruptured plaque. It could be from the neck, from a carotid plaque going up. So what do we do? So there was a trial called the Sampras Trial that said, okay, the medical management arm, that was kind of a stenting trial, but the medical management arm was dual antiplatelet therapy with aspirin 325 milligrams and clopidogrel 75 milligrams, started within 30 days of the event and treated for 90 days. But in addition, aggressive management of all vascular risk factors. And that's evidence level A. So again, you see the antiplatelets are evidence level B, but the optimization of vascular health is evidence level A. So what does the future hold for this? I don't actually, I took the slides out, but I wanted to talk to you a little bit about a research project that Dr. Pereira, Dr. Sashi Pereira here is spearheading internationally, and it's called CADIS-ICAD. And we'll talk about it a little bit later, but instead of dual antiplatelet, like we see in Sampras, there's a lot of interest to using aspirin together with a low-dose anticoagulant, rivaroxaban, low dose, 10 or 20 milligrams sometimes for like anticoagulation for stroke prevention, but 2.5 twice a day was used in something called the COMPASS trial, and it seemed to really lower risk of thromboembolism. So Dr. Pereira is actually looking at whether that aspirin plus low-dose rivaroxaban might be the thing that we're going to do in the future to lower the likelihood of strokes intracranially. But until we have the results of that trial, really, if you've determined all your other workup is negative, and you've found that someone's had a cortically based stroke and intracranially there's a stenosis, then we don't really do stenting of intracranial stenosis. It's still a little controversial. What we would do is optimize vascular health and double antiplatelet for 90 days. And then after that, people drop it down to a single antiplatelet. Yeah. So I'm going to pause again because that was some new territory. Any questions about intracranial stenosis and our approach to intracranial stenosis? Okay, we're going to continue our journey now out of the head and into the neck. Okay, so, and for this, I do apologize. I use this case all the time. Maybe some of you have seen it before. It's an interesting case. So it's basically a case of carotid artery disease. A 77-year-old woman who awoke with deficits. Her symptoms resolved within an hour. So technically, what she experienced would have been called a TIA. She's got vascular risk factors. And her CAT scan, again, a CAT scan can miss a minor stroke. And on this one, I'm going to show you right here where the stroke is. You see here, this is healthy cortex, and you can make out the gray-white matter junction very easily. The gray matter shows up as a paler shade of gray. The white matter shows up as a darker shade of gray. It's almost like a photograph negative that you're looking at. But here you can see that it's all the same darker shade of gray. And so this is a little stroke that this woman has had here. The clue is that her eyes were pointing in the direction of the ischemic hemisphere. And she had a carotid ultrasound, which I'll show you. If you haven't seen a lot of carotid ultrasounds, this is interesting. So the carotid ultrasound here, blood flow is always moving to the left of the screen. That's where the head is. This is the left internal carotid artery, and we're seeing flow through this. Doesn't look like there's any significant blockage. And then the way that we determine a degree of stenosis on an ultrasound, we put things into categories based on the blood flow velocity. So there's either less than 50% or 50 to 69%, like a moderate grade, or greater than 70%. And greater than 70% can go all the way up to near occlusion, but I'm not going to go into the details for that. This is a normal artery, and so we look at the peak systolic velocity. So here they've just measured the peak systolic velocity is 87.7 centimeters per second. So that's in the normal range. If it goes above 125 centimeters per second, that's representing usually, first of all, you'll kind of see a stenosis, and then you'll confirm it with the increased blood flow velocity. And greater than 125 up to about 230 centimeters per second is the moderate range. The interpreting physician would say this is a 50 to 69% stenosis. But if the velocity, first of all, again, you'll see it, and if it's greater than 230 centimeters per second, then it's probably a greater than 70% or a high-grade stenosis. So I'll show you just how, like, a lot of people poo-poo carotid ultrasound, but look what you can see. You would never see this on a CT angiogram. I'm not, dissing CT angiograms, but like, it's complementary information. It's not one's better than the other. So here we could see really clearly the plaque, and it's ruptured. There's a piece missing. So here is the wall of the vessel. I'm showing you where the margins, here the margins of the wall are easy to see. But here, this is the wall of the vessel, and then this is all a plaque. But you see that there's a piece of the plaque missing. So you can see in really brilliant detail a ruptured carotid plaque on ultrasound. You would never see this again on CT angiogram. And so again, we would look at the velocity of flow. And this time the velocity, remember I had told you that anything above 230, you would consider high-grade stenosis. This is 370, so it's just shot way past that. So we know that this woman has a high-grade right internal carotid artery stenosis. And that's on the side of her stroke. And obviously, this is another case of artery-to-artery embolus. So it's so important when we're speaking to patients and we're talking about blockages. I mean, people can't be faulted for thinking of a coronary paradigm. So in the heart, the coronary arteries, they are going directly into the heart muscle. So if you have a narrowing there and your heart is working very hard, then you're going to get ischemia, and you can even have a heart attack. And so, the plumbers go in there and they open it up so that you get enough blood flow to the heart. Totally different paradigm for the neck. You've got multiple pathways to the brain. So you've got the left carotid, you got the right carotid. The carotid split into internal and external. If you've got a blockage in the internal, the external can take over and get blood around the back end. You've got a posterior circulation that connects together with the anterior circulation in the circle of Willis. So it's not at all about, I mean, people sometimes go to 100% blockage and they don't even know because blood flow is still getting there. The risk is of a ruptured plaque with an artery-to-artery embolus. And so just like we were talking about intracranially, but this time a longer distance, so you could have a plaque, here's a plaque, and there's a stenosis obviously, but you've got a rupture here, and then as soon as you have a plaque ruptured, all the interior contents are really sticky, and the blood clot forms, and these blood clots obviously can't hang on because blood is squirting past there at high velocities, and then up they go into the internal carotid artery distally, and you can have a stroke. So that's what's happening in carotid artery territory stroke. And so we know very well that carotid endarterectomy, a form of carotid revascularization, will reduce the likelihood of a recurrent stroke, because if only part of the plaque is ruptured and you only had a minor stroke, a TIA or a minor stroke, there's still potential for a much bigger event if you've got a lot of plaque left. And so we've got 3 trials that were performed 20 plus years ago now that all pretty much showed that if you open up the artery and remove that plaque, then your likelihood of a stroke drops. And originally the number was 8. In other words, 8 carotid endarterectomies to prevent 1 stroke. And for moderate grade stenosis, it was 22. And that's just kind of like an average though. And this is also another slide that I always like showing. This is from a paper from Dr. Rothwell. It shows that the number you need to treat really depends on how fast you get to the patient. So because your risk of a recurrent stroke is very high immediately after the initial plaque rupture, if you wait, people just start having their strokes and they'll never come to surgery because now they're in a nursing home or dead. And so if you're waiting until like 3 months or more to get to these patients, most of the people that have lived that long, you know, if they were going to have a stroke, they would have had it. So the number to treat is like 11. There's still a chance between 3 and 6 months that somebody with a high-grade stenosis will have a stroke, but you have to operate on 11 people to prevent 1 stroke. The way you calculate number to treat is you multiply by the absolute risk reduction, so 11 times 9 is 99. Compared to in the first 2 weeks, when you've got a lot of people that haven't yet had the stroke and they're destined to in the coming weeks, you only need to operate on 3 people to prevent 1 stroke. So if you're operating within the first 2 weeks and within the first week of that first 2 weeks, you're probably getting to people fast enough to prevent a stroke. That's for the high-grade stenosis. Now, interestingly, for the moderate grade, if they're going to have their stroke, they're going to have it within the first couple of weeks, really. So if you get past 2 weeks and they haven't had a stroke, they probably aren't going to have a stroke. So you don't want to bother operating on people with a moderate stenosis after 2 weeks. But in the first 2 weeks, anything from 50 to 99% is up for grabs for surgery. And then when you kind of pool the number needed to treat, it's kind of 5 for anything from 50 to 99%. Okay, so this is stuff you all know. This is an MRI scan confirming that that area that we saw on the CAT scan is in fact a fresh infarct. So up on the top here, these are the flare-weighted sequences where damage to the brain shows up as kind of white, hyperintense, we use the term, but you don't know how old it is. So we see a little white area there, see little white specks here and there. We see some white areas here, here, here. What's old? It's all damaged, but what's old, what's new? So on the diffusion-weighted sequences down below here, you can see that this area lights up, as does this area and this area. Whereas this area and this area don't light up. So these are chronic ischemic changes, but with these, you can't really tell the difference on the flare, are fresh infarcts. It's the diffusion-weighted sequences which confirm. And these are just, this is evidence for freshly damaged brain cells. And if you were to do an MRI scan on somebody every single day after they had a stroke for like 2 weeks, the stroke would get brighter and brighter on these diffusion-weighted sequences over the first few days, and then it would get dimmer and dimmer over the next several days. And by about 2 weeks, it wouldn't show up at all anymore on these diffusion-weighted sequences. It would show up here still, but again, you wouldn't know how old it is. So if you do an MRI scan a month after a stroke, maybe you'll see the stroke, but you won't know if it was a month ago or not. If you do it within 2 weeks, you'll know if it's an old stroke or if it's the one that caused the symptoms. And so here's what a CT angiogram looks like. So compare in your minds what the ultrasound looked like, and here's the CT angiogram, and this is how they actually complement each other. The CT angiogram looks at a lot more information. So whereas the ultrasound only kind of sees this area that I'm showing you kind of here, the CT angiogram looks from the aortic arch again all the way up to the vertex. So you could see if there's another stenosis further down or further up, and if the blood vessels will connect properly in the brain and so forth. So there it is in case, let's see. And you know, we always show this slide, right? I like to showing that our median time to CEA in Central South and at the general in particular has dropped like a rock from 2012 to, you know, recent years. And that has to do with a lot of the pathways we've implemented, and it's not really the point of today's talk, but worth sharing. So let me just black out the screen for a moment. And any questions on the carotid artery disease? I think most people are familiar with what to do.
Jim, one question.
Hi, Jim.
With us doing so many more CT angiograms in the hyperacute phase, if the CT angiogram does not show any stenosis, is there a need to then do a carotid ultrasound in that situation?
Thank you. That's a really good question. No, there is not. So if you have a CT angiogram that shows that there is no stenosis, you don't need the ultrasound. And likewise, if your laboratory is performing correctly, you wouldn't need a CT angiogram if your ultrasound is negative. That's why people often use the ultrasound as a screen in the past, because if it's fine, there's no need to proceed for this. So either CT angiogram or carotid ultrasound are good at identifying normal vessels. Like they'll both tell you with a high degree of confidence there's not a plaque. But if there is a stenosis, how bad exactly it is, it's good to use both modalities to get the big picture. So that's a good question. Thanks. Now, the other thing I want to talk about. Yes?
Can I ask a question? Sorry. So if
Yeah.
somebody does, you said, so if somebody has a stenosis on the CT angio, does everybody have to have a carotid ultrasound, or do you kind of pick and choose who
Well, that's a really good question, because so I personally think yes, but many people disagree with me. So up until recently, we were doing an ultrasound as well. The surgeons like it. Like, as you have all seen, you can get a much closer look. If you're responsible, think of yourself as a surgeon. If you're responsible for going in there and removing this thing, and you want to do a good job, and you don't want to cause a problem, you know, my philosophy is measure twice, cut once, right? So you have a look at it on CT angiogram, you see it on ultrasound. There are plaque characteristics on ultrasound that can hint to the surgeon, is this going to be a friable plaque? You got to be extra careful or not? Is it mostly thrombus or not? CT angiogram can't tell you any of that stuff. But I've been kind of outvoted, and I think across the country and even in our region, it's fine to proceed with a CT angiogram alone. It's good enough. You know, I think there's value to be added by doing a carotid ultrasound as well, but that's not an evidence-based practice. That's, you know, just physician opinion. So I personally like to really understand just how, you know, how bad it is and where exactly it is and what kind of plaque it is. A lot of people say, you know, why? That's not going to change anything. Just, you know, do the surgery or stent and be done with it. So I hope that answers your question.
No, it does. Thank you.
Jim, it's Tammy. I have a question. Is there instances where somebody presents with maybe medium or high risk symptoms, so they have a hemiplegia or aphasia or whatever, that you would be more inclined to do a CTA versus a carotid ultrasound?
Because of the symptoms?
Yeah.
So I think what's happened now is really, we've gotten into the practice of doing a CAT scan on everybody that is seen in the emergency room with a TIA. Mm-hmm. And because we were arranging ultrasounds soon thereafter, they weren't bothering doing CT angiograms. Now, it's becoming more and more obvious that why not just do a CT angiogram as well as the CAT scan when they're in the emergency room?
Yeah.
And so we just went through months and months of like negotiation and debate with radiology and emergency, because nobody wanted to do CT angiograms on everybody, on every single TIA. And so we were asked to identify some high risk features. So in other words, not so much, these high risk features are more, a TIA is a diagnosis for something that's a temporary symptom. Right. So it's a temporary symptoms. It might truly have been a cerebrovascular event, but it may not have. If the symptom involved a motor weakness or speech deficits, it's just more likely that it was actually a cerebrovascular event, because there's very few things that would cause temporary weakness in an arm or temporary difficulty speaking. There's lots of things that can cause temporary numbness and tingling though. And so numbness and tingling is considered a lower risk feature because the differential is wider, and so the likelihood is lower. And so you're kind of gambling a bit. You're saying, okay, well, let's do a CT angiogram on the ones that are more likely to be actual TIAs, and we'll not do it on the ones that are less likely to be actual TIAs. And so, and I hope I'm answering the question, Tammy, but I think that's why people are doing CTAs for patients with certain symptoms but not others.
Yeah. I would agree, Jim, because I'm thinking if most patients are already going for a CT that we present to emerge, and for those that don't have like a numb thumb or some sensory, most places are moving towards doing a CTA with it. Yeah. Okay. Thank you.
Yeah. And I think we were very slow adopters, but I think it was just because of the volumes here and other factors. But I think really, if somebody has had a TIA, CT-CTA is great. Then what I would like to do is so in other words, let's flip it around. Instead of doing an ultrasound on everybody to screen and then a CTA to confirm, I kind of would want to do CTA and then an ultrasound to have another look. But people are like, we don't need the ultrasound now. And I'm like, well, I don't know. It still tells you something. Okay, so
Dr. Sahlas, sorry, I don't know if you're going to get to it. And if you are, we can pause with that. Is just when we look at treatment of high-grade stenosis, looking at carotid endarterectomy versus carotid stenting, is there different reasonings or rationale? And if we're getting to it, I'll pause my question.
Yeah, no, that's exactly the next thing I was going to say. So, so definitely we talk of carotid revascularization as opposed to just carotid endarterectomy these days. And the term carotid revascularization, open up the carotid, refers to both endarterectomy, removing the plaque, and carotid stenting. Now, what they do in carotid stenting is they go in and, again, the risk is of artery to artery embolus. So they go up with a mesh and then they just expand it and then just smush the plaque against the wall and trap anything there from escaping and going up. So it's just another way of mitigating the risk of clot going up there. You're just basically throwing down this mesh on the whole situation and then like opening up the artery and leaving it there. So there are 4 or 5 classic indications for stenting as opposed to surgery. And these include any previous radiation to the neck, because irradiated, so sometimes for cancer, people have gotten radiation for like a thyroid cancer or something. And the blood vessels obviously got caught in the radiation for the cancer. And so then you get accelerated atherosclerosis in those vessels, and those vessels are very dangerous to work with surgically, and so stenting is definitely preferred. But the other thing is, when you think about it, when you're operating on a blood vessel, the surgeons actually stop the flow to work on it. It's like stopping the traffic on the highway to do construction. So they need to kind of work quickly, because while they're working on this, the blood to this hemisphere is coming up the other side of the head and from the back, right? It's just riding on the collateral from elsewhere. So if somebody has a bad stenosis here, but they're blocked on the other side, that's another reason for stenting, because you don't want to stop the blood flow when there's no blood flow coming up the other side either. And then people that, obviously for surgery, you need general anesthesia. So if people can't tolerate general anesthesia is, another one of the classic indications, and so forth. So there's 4 or 5 classic indications, and the other one, is like a high arch. So sometimes there's just physical, people bifurcate. The common carotid splits into the internal and the external, sometimes lower where it's easily accessible, sometimes right up underneath the jaw. So the surgeon can't really access it. We call that a high bifurcation. They can't really access it easily because the jaw line is there. And so these patients should all go straight to stenting. Sometimes it's a debate, like, oh, is that high of a bifurcation or not? Like the surgeon judges, can they go for it? I think what's happening more and more, though, is that stenting is being viewed as an alternative to surgery. And I think that there's a lot to be considered. I mean, in other words, you can stent anybody, but you can't do surgery on everybody. So, so we basically save the stenting for the people that you can't do surgery, but then you do surgery on the people that you can do surgery because you don't need to stent. But now people are saying, well, why don't we stent? I think that there are some system issues that would be at play. Like, for instance, yesterday I had an EVT patient coming in, but you know, the angio suite was busy, so we had to bypass to Trillium. So that was with like an aneurysm. So now if you start adding tons of stents, what's that going to do to the hyperacute pathway is one thing to consider. And I don't know, there's a lot. I think we're having some recent discussions with our interventionists and our surgeons, and I'm not certain what the best way forward is, but you know, definitely it's stuff that we're actively exploring right now. I hope that addresses the surgery stenting issue.
Yes, thank you.
Great. Okay, so we're going at a pretty leisurely pace here. It's 2:45. Oh, I didn't know this would be animated. That's great. Okay, so this is a beating heart. So we're moving down again from the head to the heart. We've talked about brain imaging. We've talked about vessel imaging, both intracranially and extracranially, CT and carotid ultrasound extracranially, and now we're moving to the actual heart. And so I'll share with you another case. So this is a 66-year-old woman who developed right-sided weakness and speech difficulty. She's a smoker. And then here's her initial CAT scan. And on her initial CAT scan, you know, there's an older stroke maybe here, if you can see my arrow, but it's really unclear. Her left hemisphere symptoms, you know, right-sided weakness and speech difficulty, they're originating from somewhere over here, but you can't see it on the CAT scan. So again, here's where the MRI comes into handy. We see on the flare-weighted sequences up above, we see lots of little patchy hyper intensities. And down below, we see that these ones in the left hemisphere actually light up, and so they represent recent infarction. And so now this is interesting. This isn't these are subcortical, but they're not really a single spot like a subcortical lacune. This is a scattering of infarction within a territory. So at the beginning, I was telling you that there could be subcortical strokes like lacunes, and there could be cortically based infarcts, these wedges. Sometimes though, you get a large artery gets blocked and you begin to infarct within that territory, but then it opens up again. And so then you don't get the full infarction and you don't involve the cortex. And your clue that this might have been a large vessel phenomenon as opposed to a small vessel phenomenon is that you don't have a single point of infarction. You've got this scatter of infarctions throughout a large vessel territory. So this was really suspicious for either a artery to artery or a cardiac embolic clot. So we did an ultrasound and she had a little bit of plaque, but it wasn't causing any significant stenosis. We did an echocardiogram, you know, moving down to the heart. And the left atrium is something we look at because if you have a large left atrium, you're more likely to have paroxysmal atrial fibrillation. So we actually did 2 Holters on this woman. First one was negative, second one was negative. And she had frequent runs of what are called supraventricular tachycardia. So her heart would beat up really quickly, but it still didn't beat irregularly. And so she didn't really have AFib. So we said, okay, this is an embolic stroke of unknown source. ESUS is the term, ESUS. So clearly it formed from somewhere, but where, we don't know. Now, people can have clots go to the brain from, you know, the neck if they have a carotid plaque. Sometimes if the plaque is less than 50%, people think, oh, well, then I guess it wasn't that. It's not true. You can still have a stroke from a plaque that's 40% or 30%. It's just that removing it doesn't substantially lower your risk of another stroke. If you're less than 50%, you're unlikely to send off any more clots. That's why we don't operate or intervene on the less than 50% stenosis. Not because it isn't the culprit, but because even if it is, doing something won't help. Then in the actual aorta, you can have atherosclerotic plaque in the aorta, which can rupture and then go up an internal carotid artery. And, you know, that's definitely a possibility, but we don't look for it because there's not really any kind of intervention for it. Like you don't, there was a study called the ARCH study where they put people with an aortic arch atheroma on an anticoagulant to see if that was better than just antiplatelets, but it didn't really make a difference. So we don't look because it wouldn't change our management. And then in the heart itself, if we go a bit lower, there's lots of things that we know increase the risk of a stroke, but there's not much to do about it. So one is a very low ejection fraction. You know, blood can pool in the heart because of a low ejection fraction, but depending on how, like anticoagulation doesn't really help very much. I'll talk a little bit about PFOs and so forth. And then obviously there's atrial fibrillation. If the person's in chronic atrial fibrillation, it's one thing, but atrial fibrillation can come and go. And so sometimes we miss it. So if you come up blank on all your investigations, we call it an embolic stroke of unknown source. So in this lady, we treated her for hypertension, we gave her a statin, we got her to quit smoking, and she's discharged just on aspirin. 2 years later, she came back with new symptoms of speech difficulty. And when her symptoms failed to improve, she came to the emergency room. And now we see in between her first admission and her new admission now, 2 years later, there's this big black area, which is well-established stroke. Now, her speech symptoms are left hemisphere symptoms. So we would look in the left hemisphere. And I don't know if you can make out this bright white dot. That is called a Sylvian dot sign. This is the Sylvian fissure, named after this guy who called himself Sylvius and mapped the brain. So this is the Sylvian fissure, and the middle cerebral artery, a branch of it, the M2, one of the M2 segments, is coming right out of the screen at you. So you're getting it in cross section, and if there's a clot in it, it shows up as hyperdense. So this is the smoking gun. The woman's presenting with symptoms, and we've got a hyperdense vessel in the territory that would be causing the symptoms. And we're also seeing some patchy hyperdensities that, now this might be her stroke from 2 years ago. Remember where those changes were? But is this something new? Who knows? This, she's actually coming back with her third stroke. Her first stroke was when she came in and we investigated her. Then in between that and this, she had this second stroke in the right hemisphere because it's already well established and quite dark. When it gets this black, you know it's like at least a year old or something. And now she's coming back with a third event, this time in the left MCA. Now, you may ask, well, that's a pretty big stroke. Why didn't she actually know? The right hemisphere, people can have a stroke in the right hemisphere, and it may not be obvious for two reasons. One, it's not going to involve language the way, if this was on the other side, this would have involved her speech, and she would have become aphasic. Now, we use both hemispheres to communicate. The left hemisphere is more the words we say. The right hemisphere is the way that we say them. So your right hemisphere is your tone of voice, you know, your facial expressions, your body language, all your nonverbal communication. And people aren't as attuned to if, you know, nonverbal communication is something that we don't really draw attention to normally. And so you could lose your aptitude for nonverbal communication. You may begin missing sarcasm and all that kind of stuff, but you don't really know because, you know, those are kind of under the radar aspects of our communication. So she had, the other reason that you may not notice a right hemisphere stroke is that your right hemisphere, sometimes you can get neglect. And so your deficits aren't apparent to you. So anyway, it's not uncommon for someone to roll into the hospital and for us to see a hitherto unsuspected right hemisphere stroke. But yeah, so what's going on? So here's her MRI again. And this time we see, again, this is old. It gets old. But down here, we see a little speck here and here and here. So she's thrown another clot that's broken up and gone into the MCA again. And we repeated her again. Her ultrasound was fine, but her Holter did show 8 runs of atrial flutter fibrillation. So we started her back then. This was a while ago. We started her on warfarin. So one of the things that we do in our workup for a stroke is on our way from the top down, when we get to the heart, we're most interested really in whether or not there is atrial fibrillation. We're obsessed with it. So we pour over the, for us, the biggest fear is that there's an electrocardiogram somewhere that shows that the person has AFib and everything else was negative, and we missed the opportunity to start them on anticoagulation. Or sometimes in the echo report, it actually shows that there was atrial fibrillation, but it wasn't really done for the rhythm. I just mention it. And believe it or not, I have diagnosed atrial fibrillation on a carotid ultrasound many times, because you remember how you can see the actual beats of the heart on an ultrasound? So when I'm reporting on a carotid ultrasound, if I notice that the heart is irregular, I mentioned it in my report, irregular heart rhythm noted, rule out atrial fibrillation. So you really want to have your radar up all the time for it. And the reason, of course, is that it really elevates the risk of stroke. You can stratify the risk with something called the CHADS-VASc score, which you can kind of Google and go into all the criteria. But the concern is that a clot forms and goes up and causes a stroke. And these days, because it can be elusive, we really encourage prolonged ECG monitoring for at least 2 weeks. So we do a lot of 2-week loop recorders these days. If the Holter monitor exam is negative, if telemetry, so-called, in the hospital is negative, and if everything, even if first 24-hour Holter is negative, then we go right to a loop recorder at minimum these days. And then if we do find atrial fibrillation, we use the direct oral anticoagulants, which we used to call the NOACs, the new oral anticoagulants. I think it's actually Dr. Hart that might have coined the term DOAC from NOAC. But anyway, these are the non-vitamin K oral anticoagulants like apixaban, dabigatran, edoxaban, and so on and so forth. Now, there's another place that we use those, and I just want to talk about the COMPASS trial again. So something that hasn't entered the best practice recommendations yet, but that probably will, is the COMPASS regimen. They enrolled people with an asymptomatic carotid stenosis into COMPASS, and they found in those patients, if you put them on low-dose rivaroxaban, 2.5 milligrams a day, in addition to the aspirin, they had a lower risk of a first stroke from that asymptomatic carotid stenosis. So obviously with knowledge translation and stuff, it takes time to penetrate into practice, but I noticed that more and more of my colleagues, I mean, it's still not entered the best practice recommendations, for Canada, but more and more people, if you're working up somebody and you find an asymptomatic carotid stenosis, we used to always add aspirin to prevent a first stroke from the carotid territory, but now we add aspirin and low-dose Riva, the 2.5 BID, for an asymptomatic stenosis. I'll finish. I don't even know what time it is. It's 3 o'clock. So I'll finish with the echocardiogram. And so echocardiogram is kind of like the last test on the list, because you're unlikely to find something that's going to really influence management. The biggest thing you're going to find is atrial fibrillation that was missed on everything else. Sometimes people will be in atrial fibrillation on their echocardiogram. And what this one is demonstrating is a right to left shunt. That's what the yellow arrow is pointing to. You can see the little space between the right and the left atrium. And so what is a right to left shunt? Well, normally blood comes into the right side of the heart and gets pumped out to the lungs. Then it comes back to the heart, the left side of the heart, and then gets pumped out to the brain. And sometimes people can form clots in their legs or what have you, a DVT, and a clot can move up to the right atrium. And normally you'll get a pulmonary embolus, like the heart will pump out the clot to your lungs, which is normally what works. But 1 in 10 of us actually have this actually all of us have a PFO when we're born, and then it closes in 90% of us, but about 10% of people still have a patent foramen ovale. And so instead of getting sent to the lungs, a clot can actually bypass the lungs and get sent right up to the brain and cause a stroke. And so what do you do for patients with a PFO? So it still remains a little bit debatable and controversial. Going back 20 years, it wasn't clear whether aspirin or anticoagulation or a device closure, a PFO closure, surgical closure, was the right thing to do. And there were some trials and the outcomes all seemed similar. So for many years, we only just put people on aspirin. And a few years ago, there were a few trials that came out. Most stroke physicians acknowledge that these are flawed studies. To give you an example, when you really try to dig deep, like these studies said that these people presented with TIAs or strokes, and they had a PFO and it was closed, and then, you know, versus not, and the people that had it closed, they were less likely to have a subsequent event. But the only reason those studies were positive is that subsequent events included TIAs in addition to strokes. And when you look for details on the TIA, they're very wishy-washy. And if you remove the TIAs, the studies are negative. So the evidence that Pfo closure is actually beneficial is based on a couple of studies where they include, in addition to strokes, other transient events that they call TIAs. And as we all know, a TIA might be a TIA, it might not be a TIA, and even who cares about a TIA? It doesn't do any damage. So again, if you look at those studies and only look at the stroke outcome, then it's not really indicated. So Pfo closure is something that we will consider in, you know, select cases, and it's usually in younger people with no vascular risk factors. Younger meaning they've got a greater lifetime risk of a stroke. Certainly you wouldn't do Pfo closure in an older person with vascular risk factors because, you know, A, for it to be a benefit, they got to live another 30, 40 years. And then B, you know, it's probably a stroke in their age group because of vascular risk factors or some other reason anyway. But if it's a younger person and it's a big PFO and they have no other reason for stroke, yeah, then we'll send those people for closure, is what myself and most of my colleagues are doing right now. So I just wanted to kind of include this last slide. This is actually a slide that Lisa Franzi contributed, and then really it's the concept of wraparound care. So a lot of our patients, I realize this is an acute stroke workshop for patients that are admitted to hospital, but even for TIA and minor stroke, what we attempt to do is same day vessel imaging, same day put the Holter patch on, same day blood work, get MRIs quickly, echoes quickly, same day smoking cessation, rapid access to carotid intervention, personalized visit summary, all this really, it's patient-centered care. So it's important to, as we all know, make the patient the reason that we're doing everything, and to make the system work for the patient, not the other way around. Yeah, I think, you know what, that is actually my last slide. I'll stop sharing. And I always get nervous when I speak for such a long time. It's 3 o'clock, so I think at this point, looking at the original schedule, I think I was supposed to finish around now. Is that right, Rhonda?
I think you actually had a bit more time. We'll finish now, and then we have more time for some questions.
Okay.
So excellent presentation, Dr. Sahlas. Thank you so much. Are there any other questions for Dr. Sahlas? I have a few, but I will be quiet. You can either write them in the chat, and there's a comment. You are very easy to listen to. Thank you. You can either write them in the chat or unmute and ask your question.
Jen,
I have a question.
Oh, sorry, go ahead.
Sorry. I have a question about, so you mentioned in intracranial stenosis, dual antiplatelet therapy for 30 days up to 90 days, and then stepping down to 1 antiplatelet. Is there any evidence in somebody who has no other cardiac risk factors, no MI, what the optimum antiplatelet is? Like, are you better off choosing aspirin over Plavix versus Plavix over aspirin over clopidogrel versus? Yeah.
Yeah, so I think the difference between aspirin and clopidogrel is very small. It only becomes relevant if the person is at a very high risk of stroke in general, and not just stroke, other vascular events. So you might choose Plavix over aspirin if the person's got triple vascular bed, so stroke issues, cardiac issues, peripheral vascular disease issues, or because it's a little bit easier on the stomach, you might choose it if the person has gastric intolerance to aspirin or an allergy to aspirin. But in terms, just to put it into perspective, well, there's no evidence that Plavix is more effective than aspirin in preventing stroke. The trial that showed it was slightly more effective if you take combined endpoints of an event in the brain, event in the heart, event in the leg, still was a number needed to treat of 200. So you need to put 200 people on Plavix instead of aspirin, and that's not even to prevent a stroke, it's to prevent some event. So I favor aspirin because it's easy to, you tell a person to take aspirin for the rest of your life and they just do. A bottle has 4 months supply in it because it'll have 120 tablets and they don't need a prescription. So if they run out, there's not going to be a gap. So my preference is aspirin, but it really doesn't matter. I would regard them as equivalent.
That's great. Thank you very much.
Any other questions?
Jim, the combined therapy of aspirin and low-dose Riva, is it just not in the best practices because it's so new in terms of the evidence coming out? I'm assuming the plan is for it to be entered into the best practice recommendations?
Yeah, I think so, because some of the trials, some of the subgroup analysis only published in the past 12 months, and then we've got COVID and everything. So I'm surprised that it's not there yet, because traditionally Patty Lindsay would be pretty nimble with stuff and get it in really quickly. The other thing is it's only one study, so it wouldn't be, I mean, you need 2 RCTs and it was a subgroup analysis. So it's something that, if there's another trial and it's shown not to be helpful, but yeah, in general, I think people are having a difficulty knowing how strong to advise regarding its use. We've known about it for about 18 months now. I wouldn't be surprised if in the next 6 months there's some kind of a statement, but it's taking a while to penetrate into practice.
And they're just in the process right now of updating the secondary stroke best practices. So I think it'll be released shortly.
Oh, there you go.
Yeah.
Okay, perfect. And they'll probably say something like, for these patients, ASA plus low-dose Rivas may be considered. Like, I think it's going to be something like that. So it's not like the EVT trials that it was like, wow, these are life-saving, huge things. The number to treat is something like 30 as well. Like, it's a high number needed to treat. So it's of modest benefit, and it's good to know about. Yeah.
Any other questions for Dr. Sahlas?
Janice Wright from Niagara, nurse practitioner in the rehab setting. I found the talk was excellent, and it really does help me when I'm looking at patients and as they're coming in from the acute stroke unit. We also have patients that come in from non-stroke units around Niagara, and there is a variability in aspirin, Plavix, the length of the acute care prescription. So one of the things we do in the rehab setting is to go back and look at the type of stroke, and then for discharge, give the patient the best information, and then they go on to secondary stroke prevention as well. But we do see a lot of variability in terms of dual antiplatelet therapy for this amount of time, sometimes for 21 days, flipping back and forth between ASA and Plavix. And I welcome your comment on Plavix, as I also think that ASA is something that patients won't forget to take. They won't forget to refill their prescription. So certainly it seems to be one that's easier to manage for patients. So I think one of the things, I think my take-home message is review your scans, know your stroke location, know the type of stroke, and then very much organize the secondary prevention components around all of those factors. So it was a really excellent presentation.
Yeah, thanks. Yeah, I think bottom line, aspirin, Plavix doesn't really matter. But in terms of the 21 days, that's probably because, and I avoided this because it's basically we know from the POINT and the CHANCE trials now that if you, on the day of the event, that's very key. If on the day of the event, you start someone not just on aspirin or Plavix, but on both, that the likelihood of an early recurrent stroke is much less. So we're talking about a stroke in the initial days after the event. It's something that's been tried many times over, and nobody could ever find that dual antiplatelet was better than monotherapy until they did trials where they started the dual on the day of the event. So if it's going to do any good, it's going to be the event, and then those trials were for the 3 weeks. So you're going to see a lot of people with the dual antiplatelet for 3 weeks. Then people step down to aspirin or Plavix for 2 reasons. I think in the trials, they stepped down to Plavix. you know, but really aspirin, I think one of the trials is aspirin, one of the trials Plavix. So I think the bottom line is it doesn't matter if it's aspirin or Plavix, you know, afterwards. I just have a preference for aspirin. I find aspirin as well, a lot of people are really anti-medication. And sometimes aspirin is the only thing I get them to take, because I tell them, look, aspirin has actually been used by human societies for millennia, because it's actually extract of willow bark. And so primitive societies have used, you know, willow bark tea and willow bark aspirin, and people are like, oh, I'll take it then. Like if it's something that's kind of natural. And it is. Aspirin's kind of like something that's naturally occurring. It's a subtle salicylic acid, and it's in willow bark. So I think that is a way to kind of get people to take an antiplatelet if they're just averse to all medications.
Any other questions? I know I have one, but I'm often, if I pause long enough, somebody will ask my question. So I'll let others go. Okay, I'll ask my question. So, Dr. Sahlas, we're seeing strokes in younger and younger people on our stroke units. And when I say that, it, you know, in their late teens, early 20s, 30s. Are there different investigations we may do either in addition or differently with these younger patients to figure out what causes of strokes they may have?
Yeah, that's a good question, actually. So from some of the rare reasons, so with somebody that's young without a lot of vascular risk factors, we sometimes worry about the possibility of a vasculitis, a cerebral vasculitis. That could either be primary vasculitis of the brain, or it could be secondary from something like lupus. In my experience, it's really rare, and the treatment is very intense. But you can do an MRI with gadolinium, you know, the MRI contrast, doing something called vessel wall imaging. And, you know, just to share with you, I had a recent kind of, not the best experience with that. So our radiologists are just starting to use the vessel wall imaging. And there was a younger woman who smoked, and, you know, I thought probably it was just her vascular risk factors, but, you know, they reported it as, oh, you got to really think about vasculitis, and oh, you got to really think about vasculitis. And I spoke to two of the radiologists, and they said, no, I really think this is probably vasculitis. And so I said, okay, well, if you really think it's probably vasculitis, now we have to do a brain biopsy. You know what this means? We have to open up her skull and take a piece of her brain and look at it. And they're like, yeah. So we did, and then and it was negative, and then we discussed it in rounds with all the radiologists. Most of them said, no, it doesn't look like vasculitis. So I've kind of basically gotten a little bit more skeptical about this vessel wall imaging. I think with any kind of new imaging modality, you need a lot of experience with it. And when you talk about taking a piece of the person's brain out, you know, you got to be, it's the right hemisphere, you know, it's not a big deal, but still. Yeah, so there's vasculitis. That's really rare. I've only seen 2 cases, I think, ever. And then the other thing that we do for younger people is a hypercoagulable workup. And a lot of these tests like protein C, protein S, looking for deficiencies there, or anticardiolipin, they're kind of expensive to run. And so you're not even allowed to order them unless you're a hematologist, because the hospital is trying to cut costs. And we actually got an exception for some of the stroke physicians, because we're not ordering. I think somebody were just ordering a hypercoagulable workup on every patient, and so that was, you know, not really fiscally, you know, responsible. So the thing about a hypercoagulable workup is, again, there's not an evidence-based intervention for it. So and what the hematologist will tell you is that if somebody has, say, a protein C deficiency or protein S deficiency, they're more likely to have a venous clot, not really an arterial clot. So then it only becomes relevant if they also have a PFO. And then the anticardiolipin antibodies, you can have an arterial clot, but it's still debatable whether you should do anything different than just aspirin. Like some people at one point were using anticoagulation for the anticardiolipin antibodies that can genetically be seen in some people. And now more recently we've pulled back from that, and it's not sure that it really works. So I think for the so-called stroke in the young, very often in younger people, it's the usual suspects. Very rarely you'll see something like a vasculitis, or even more rarely you'll see like a super large PFO. I think the number one thing that we've done is close PFOs in young patients who have no other risk factor. So I hope that answered your question, Rhonda.
I have one other question. So we sometimes will see patients will have a transthoracic echocardiogram, and then we'll go on to have a transesophageal echocardiogram. What would be the indications for either of those, and why would we do I know we start with the transthoracic. Why would we then do a TEE?
Well, that's a good question. It's almost related to your earlier one too. So a transthoracic echocardiogram, they're doing the ultrasound across the chest, and they have to go through the sternum, so it's not as clear of a picture. Transesophageal, they sedate you and they put the probe through your throat, and you're lying down, they're examining the heart, like looking with the probe down through your throat. You know, people don't remember much because they're sedated, but it's not the best experience. So often you'll see stuff on a transesophageal that you won't see on a transthoracic. So if on a transesophageal, you'll see a PFO that you couldn't see on the transthoracic. Really, I think the best indication for transesophageal is if you do see an abnormality on the transthoracic, and then just how bad is it? You use the transesophageal to better characterize it. Because if you don't see anything on the transthoracic, then even if you see something on the transesophageal, it's probably clinically insignificant, right? If something is so small you can't even see on the transthoracic, forget it. But sometimes, again, for stroke in the young, people will want a transesophageal instead of a transthoracic because they really want to be sure there's not a PFO. I mean, that's the practice, but I don't know that it really makes a big difference because you're not going to really close a PFO that's really tiny anyway. But you know, in stroke in the young, people usually do a transesophageal. And there's another thing that we haven't talked too much about, but that's transcranial Doppler. It's only available in some centers, but with transcranial Doppler, it's actually the best way to tell if there's a right to left shunt. So what you do is you actually put on the ultrasound probes, and then you just use a syringe and you agitate some saline and you inject it into the vein. And then if those bubbles show up in the brain, then they got there somehow, usually across a PFO, sometimes across a pulmonary shunt. So transcranial Doppler monitoring for microemboli will, if it's negative, nothing is coming from the right to the left, right? So you might see a little PFO and you're wondering, is it clinically significant? Well, to figure out how bad it is, you can do a Tcd study, and then that'll tell you functionally how many bubbles and particles are crossing from one side to the other. And they're just air bubbles, so that doesn't hurt the brain. So there are additional tests that we can do, but it's in a very small portion of patients. Like I would say like 1 in 40. Most young people that have strokes have it for the usual reasons.
Thanks, Dr. Sahlas. Any final questions?
Actually, there's another, if we're going to expand kind of the investigations, there's another wave of investigations that we do. If somebody has had a stroke and we've done the whole workup and we haven't found a cause, and they come back and they have another stroke, we sometimes look for evidence of malignancy because a malignancy can make the blood hypercoagulable. Also, if somebody's got AFib and they have a stroke on anticoagulation and they come back and they have another stroke on anticoagulation, something is overpowering the anticoagulation. So we'll often do a CT scan of the chest, abdo-pelvis, looking for an occult malignancy if somebody's having recurrent strokes despite everything. But usually there's a clue. There's been recent weight loss or something else. So usually there's some indicator, but it's not uncommon at all. I think once every month or two, we see somebody on the ward that, they're having a stroke because of an underlying malignancy.
Any further questions? So thanks, Dr. Sahlas, for a really amazing presentation. You make it so easy to understand and really easy to help understand what our patients are going through. and the tests and why they're on the various stroke prevention that they're on. So Barb, I'm going to turn it over. You're going to put us in our breakout sessions, and what we're going to do before we move to the wrap up is the questions that we're going to look at now. I'm going to just, oops, I have to share my screen before I pull it up. Oops.
Sorry, I'm re-randomizing.
Okay, so while Barb's doing that, what we're going to do is really taking the information that Dr. Sahlas has talked about and really looking at how can we provide that education to our patients about why they're going through the various tests, and then really what education will we provide them on why they're on the secondary prevention and what can they do to help prevent a secondary stroke. So we'll do that. We'll do that for about, we'll see about maybe 15 or 20 minutes, 15